For years, we've been taught to give large volumes of intravenous fluids before reaching for vasopressors. But what if starting vasopressors earlier and giving substantially less fluid doesn't improve outcomes after all? In today's episode, we'll examine a landmark randomized trial that challenges one of the most debated questions in critical care. We'll also look at a rehabilitation strategy that unexpectedly improved survival after mechanical ventilation, and finish with one of the most practical reviews you'll read this year on diagnosing pleural effusions. These are studies that could influence how you practice next week. Hello everyone, and welcome back to This Week in Pulmonary and Critical Care Medicine, where we review the latest evidence that matters for clinicians caring for patients with respiratory disease and critical illness. Every week we focus on studies that have the potential to influence bedside decision-making, not simply because they're new, but because they challenge assumptions, reinforce good practice, or teach physiology in a way that changes how we think. Today's episode covers 3 very different but highly relevant papers. Let's begin with septic shock. Few areas of critical care generate as much debate as the first few hours of septic shock management. Most clinicians agree that restoring tissue perfusion rapidly is essential. The disagreement has always been how to achieve that goal. Should we aggressively administer intravenous fluids first, accepting the possibility of fluid overload? Or should we start vasopressors much earlier, limiting fluid administration and potentially avoiding edema of the lungs, kidneys, and other organs? Both approaches have physiological advantages. Both also have potential harms. Despite decades of practice, we've had surprisingly little high-quality randomized evidence comparing these two competing strategies during the earliest phase of septic shock. That is exactly what the ARISE Fluids investigators attempted to answer. Published in the New England Journal of Medicine in June 2026, this multicenter randomized trial enrolled 1,000 adults presenting to emergency departments with early septic shock across 51 hospitals in Australia, New Zealand, and Ireland. Patients had persistent hypotension despite receiving at least 1 liter of intravenous fluid, elevated lactate concentrations above 2 millimoles per liter, and had already received antibiotics. Participants were randomized to one of 2 fundamentally different resuscitation strategies. The first strategy emphasized early vasopressor initiation with restricted additional fluid administration. Immediately after randomization, intravenous fluid resuscitation essentially stopped unless specific rescue criteria were met. Vasopressors were started promptly, while maintenance fluids were discouraged. The second strategy reflected what many clinicians would recognize as conventional care. Patients continued receiving additional intravenous fluid boluses, aiming for approximately 30 milliliters per kilogram, with vasopressors introduced only after clinicians judged that adequate fluid resuscitation had been achieved. Importantly, this was not a comparison of fluids versus vasopressors. Both groups ultimately received both therapies. The real question was timing. Could earlier vasopressors combined with substantially less fluid improve patient-centered outcomes? The primary outcome was particularly meaningful: days alive and out of the hospital through day 90. Not simply survival, not ICU length of stay, but a composite measure reflecting both mortality and meaningful recovery. And here's where things became interesting. During the first 24 hours, the intervention clearly changed clinician behavior. Patients in the early vasopressor group received approximately 1.1 liters less intravenous fluid, while vasopressor use increased by nearly 19 percentage points compared with the conventional strategy. So the trial successfully separated the 2 treatment approaches. The intervention worked, but did patients actually do better? The answer was no. The median number of days alive and out of the hospital at 90 days was 76 days in both groups, with absolutely no statistically significant difference between the strategies. That finding deserves attention. For years, clinicians have argued that earlier vasopressors might improve outcomes by minimizing fluid overload while restoring vascular tone sooner. This large randomized trial found no evidence that this strategy improved the primary outcome. Likewise, mortality outcomes remained remarkably similar between groups. At first glance, that might appear disappointing, but negative trials can be just as important as positive ones. They help define what doesn't meaningfully change patient outcomes. However, the study did reveal one clinically relevant difference. Pulmonary edema occurred far less frequently in the early vasopressor group. Only 0.6% of patients experienced pulmonary edema, compared with 5.0% in the more liberal fluid group. That represents an absolute difference large enough to catch every intensivist's attention. Does this mean everyone should start vasopressors immediately? Not necessarily. One important limitation deserves consideration. Although this trial compared two protocols, actual vasopressor choice, blood pressure targets, assessment of fluid responsiveness, and ongoing resuscitation decisions remained at clinician discretion. That reflects real-world practice and improves generalizability, but it also introduces variability that could dilute treatment effects. Another important point is patient selection. These patients had already received at least 1 liter of fluid before enrollment. The trial therefore doesn't answer whether vasopressors should replace the initial fluid bolus altogether. Instead, it informs what should happen after that initial resuscitation. Perhaps the most important lesson is conceptual. For years, the discussion has often been framed as fluids versus vasopressors. This trial reminds us that septic shock management is rarely that binary. Patients need both. The challenge is determining the right balance for the individual patient rather than rigidly following a fixed volume target. That's probably the biggest takeaway from ARISE fluids. The study does not support abandoning intravenous fluids, nor does it demonstrate superiority for routine early vasopressor initiation. Instead, it weakens the argument that one standardized resuscitation strategy is universally better than the other. In practice, this means clinicians can be more confident individualizing early septic shock resuscitation based on physiology, evidence of fluid responsiveness, and risk of fluid overload, rather than feeling obligated to pursue a fixed fluid target before initiating vasopressor therapy. One of the greatest successes in critical care over the past 2 decades has been improving survival from acute respiratory failure. But survival is only part of the story. Many of our patients leave the ICU profoundly deconditioned. They struggle with weakness, dysphagia, anxiety, depression, cognitive impairment, and loss of independence, problems that often persist for months after discharge. We've tried many strategies to address post-intensive care syndrome. Early mobilization, ICU diaries, follow-up clinics, post-discharge rehabilitation programs, and telehealth have all shown promise. Yet randomized trials have produced inconsistent improvements in long-term quality of life. That raises an important question. Perhaps we've been treating rehabilitation as isolated events rather than a continuous process. Instead of asking whether rehabilitation in the ICU works, what if recovery begins in the ICU and continues seamlessly through the ward and into the patient's home? That was the premise behind the Telerehab MV trial, published in JAMA in June 2026. This was a stepped wedge cluster randomized trial involving 20 public hospitals in Brazil. The investigators enrolled 1,916 adults with acute hypoxemic respiratory failure requiring invasive mechanical ventilation. Hospitals gradually transitioned from usual care to the intervention over predefined time periods, allowing every participating center to eventually implement the rehabilitation program. Importantly, this was not simply a telerehabilitation study. It was a comprehensive system redesign spanning the entire recovery pathway. During the ICU phase, teleconsultants supported local teams in implementing evidence-based liberation practices, including lighter sedation, analgesia optimization, spontaneous breathing trials, delirium prevention, early mobilization, and timely removal of unnecessary invasive devices. Once patients reached the ward, centralized rehabilitation specialists performed structured assessments for nutritional deficits, dysphagia, reduced physical function, anxiety, and depression. Individualized rehabilitation plans were then initiated before discharge. After discharge, patients entered a 2-month personalized telehealth rehabilitation program coordinated by nurse telenavigators to ensure continuity of care. The primary endpoint was health-related quality of life at 90 days, measured using the EQ-5D3L utility score. Unlike many ICU trials that focus primarily on mortality, this outcome reflects how patients are actually functioning after surviving critical illness. The investigators found a statistically significant improvement in the primary outcome. The mean EQ-5D utility score was 0.16 in the intervention group compared with 0.12 with usual care, yielding an adjusted difference of 0.049. Notably, this difference falls within the estimated minimal clinically important difference for this instrument. At first glance, that appears to support the effectiveness of the rehabilitation program. But the investigators then performed an important analysis. When they looked only at survivors, the quality of life scores were essentially identical, 0.60 versus 0.59, with no statistically significant difference. That changes the interpretation considerably. The improvement in the overall quality of life endpoint was driven largely by more patients surviving, rather than survivors experiencing substantially better health status. And that brings us to the study's most surprising finding. 90-day all-cause mortality was 71.8% in the intervention group compared with 78.3% in the usual care group, and an adjusted absolute difference of minus 7.6%. Patients also required significantly fewer days of mechanical ventilation, 9.9 days versus 15.5 days, with an adjusted reduction of 6.2 days. Those are impressive findings, yet they also warrant careful interpretation. The intervention was multi-component. It combined ICU liberation practices, structured multidisciplinary rehabilitation, telemedicine support, care coordination, and post-discharge rehabilitation. Because all of these elements were introduced together, it is impossible to determine which component, or combination of components, produced the observed benefit. In addition, the stepped wedge cluster design is well suited for evaluating health system interventions, but is inherently more vulnerable to secular trends and differences in implementation fidelity than an individually randomized trial. These factors should temper any assumption that telehealth alone explains the mortality signal. Perhaps the most important message isn't that telemedicine saves lives. It's that recovery from critical illness should be viewed as a continuum rather than a series of disconnected episodes of care. This trial integrated liberation from mechanical ventilation, multidisciplinary rehabilitation, and structured post-discharge follow-up into one coordinated pathway. The mortality benefit may reflect the cumulative effect of consistently delivering multiple evidence-based practices rather than any single innovation. In practice, this means we should think beyond isolated ICU interventions. Programs that connect evidence-based ICU care with structured rehabilitation on the ward and after discharge may have greater impact than focusing on any one phase of recovery alone. While the mortality findings require confirmation, this study strengthens the argument that recovery from critical illness begins on the first day in the ICU, not on the day the patient leaves the hospital. Let's finish this week's episode with something a little different. Not a randomized trial. Not a new drug. Not a new procedure. Instead, an outstanding clinical review that reminds us why good bedside medicine still matters. Every pulmonologist has experienced this scenario. A patient presents with a pleural effusion. The thoracentesis is performed. The pleural fluid results return. And yet, the diagnosis is still uncertain. We've all been trained to focus on pleural fluid analysis. Is it a transudate or an exudate? What is the LDH, the protein, the glucose, the pH? Those are important questions. But as Chopra and colleagues argue in their excellent review published in Chest in June 2026, pleural fluid analysis alone rarely establishes the diagnosis. Instead, its true value comes from integrating the results with the patient's history, physical examination, laboratory studies, and imaging findings. Think about that for a moment. This is where many clinicians make their first mistake. We often ask, what does the pleural fluid tell us? The better question is, does the pleural fluid make sense in the clinical context? That distinction changes the entire diagnostic process. The authors begin with one of the simplest but most overlooked tools we have, the patient's history. Certain historical clues dramatically narrow the differential diagnosis before a needle ever enters the pleural space. For example, the tempo of symptoms matters. An effusion developing over hours or a few days points toward acute processes such as perimnemonic effusion, pulmonary embolism, traumatic hemothorax, chylothorax, or acute decompensated heart failure. In contrast, an effusion that has remained stable for more than 6 months has a much narrower differential. Chronic trapped lung, chronic kidney disease, post-cardiac surgery effusions, cholesterol effusions, chronic empyema, and tuberculous empyema become much more likely. Exposure history is equally valuable. The review reminds us to think beyond the obvious. Previous thoracic radiation should raise suspicion for radiation-induced pleural effusion, which may occur months or even years after treatment. Prior coronary artery bypass surgery introduces several possibilities, including post-cardiac injury syndrome, chylothorax, hemothorax, heart failure, or trapped lung physiology. These diagnoses are often missed if we focus only on pleural fluid chemistry. Medication history deserves the same level of attention. Drug-induced pleural effusions are uncommon but probably under-recognized. Among modern therapies, tyrosine kinase inhibitors, particularly dasatinib, are among the most frequent causes. Immune checkpoint inhibitors have also been associated with pleural effusions, creating a particularly challenging situation because the effusion may be mistaken for progression of the underlying malignancy rather than treatment toxicity. The review also highlights the importance of imaging, not simply to detect fluid, but to characterize it. Thoracic ultrasound tells us far more than whether fluid is present. Is the effusion free-flowing or loculated? Are there septations suggesting pleural infection? Is the pleura thickened or nodular, raising concern for malignancy? These findings substantially alter the diagnostic pathway before laboratory results are even available. Likewise, CT imaging can reveal associated parenchymal disease, mediastinal lymphadenopathy, pleural thickening, or evidence of previous surgery or radiation that immediately changes the differential diagnosis. Here's another teaching point that deserves emphasis. Light's criteria answer only one question: whether the pleural fluid behaves as a transudate or an exudate. They do not identify the underlying disease. An exudate is not a diagnosis. A transudate is not a diagnosis. They're simply physiologic categories that help direct the next step in evaluation. That's an important distinction. The number hasn't changed, the meaning of the number has. The authors repeatedly emphasize that diagnosing pleural disease requires pattern recognition. Clinical history, imaging, pleural fluid analysis, blood tests, prior procedures, medication exposure, geographic risks, and comorbidities should all point toward the same diagnosis. When one piece of information doesn't fit the overall picture, that's the moment to pause and reconsider, rather than forcing the data to match the initial impression. Like any review article, this paper doesn't generate new evidence or compare diagnostic algorithms in a randomized fashion. Its value lies in synthesizing existing knowledge into a practical bedside framework. As a narrative review, many recommendations reflect expert interpretation rather than graded evidence, so clinicians should continue to integrate current guidelines and disease-specific data when making management decisions. In practice, this means don't let pleural fluid analysis become the centerpiece of your diagnostic reasoning. Use it as one component of a broader clinical assessment. The most accurate diagnosis usually emerges when the patient's history, imaging, laboratory findings, and pleural fluid all tell the same story. And perhaps that's the lasting teaching point from this review. Pleural fluid rarely gives you the diagnosis. Good clinical reasoning does. As we wrap up this week's episode, 3 very different papers leave us with a common message. The ARISE Fluids trial reminds us that long-standing practices deserve continual re-examination. Early vasopressors combined with a more restrictive fluid strategy reduced pulmonary edema but did not improve the primary patient-centered outcome. Rather than proving one approach superior, the study reinforces the importance of individualized resuscitation based on physiology instead of rigid protocols. The Telerehabilitation trial shifts our perspective beyond survival. Recovery from critical illness doesn't begin at ICU discharge. It begins on the first day of admission. Coordinating evidence-based care across the ICU, the hospital ward, and the patient's home may ultimately matter more than any single rehabilitation intervention. And finally, the CHEST review reminds us that good clinical reasoning remains irreplaceable. Laboratory values are helpful, but they are only one piece of the puzzle. The diagnosis of a pleural effusion rarely comes from pleural fluid analysis alone. It emerges when history, imaging, laboratory findings, and physiology all point in the same direction. Perhaps that's this week's unifying lesson. Evidence changes practice, but evidence also changes how we think. Sometimes the most important studies don't tell us to do something completely different. They teach us to ask better questions. If you found this review helpful, consider subscribing so you don't miss next week's evidence update. Until next time, stay curious, keep questioning assumptions, and remember that today's evidence shapes tomorrow's bedside decisions. Thanks for joining me for another edition of This Week in Pulmonary and Critical Care Medicine.